The author has no financial interest in this presentation. What follows is a video case presentation of a surgical technique, Open Sky on the Sly, penetrating keratoplasty made safer by never allowing the anterior chamber to be completely open to atmospheric pressure. Penetrating keratoplasty, open sky, is inherently risky in the sense that zero atmospheric pressure allows for an increased chance of serious complications like expulsive hemorrhage, retinal extrusion, and various other mispositions and complications that can occur, especially in the light of patient movement, coughing, increased posterior pressure, etc. Dr. Price has previously described a technique where the host corneal button was held in position by stay sutures and the donor button partially sutured in above the host, and then the host removed from underneath the donor corneal button. This is a modification of that technique, except that no extra suturing is required. Here the corneal trephine has created a large full thickness incision on one side of the button about to be removed. A viscoat cannula is inserted in the anterior chamber to fully reform the chamber, and now a super sharp blade is used to make a small incision on the opposite side. We now have a donor button that is held in place by two areas of tissue connection and has two separate areas of cleavage between the rim and the host button. Corneal scleral scissors are used to extend the areas of cleavage between the donor and the rim. However, two small tags of posterior corneal tissue are left in place superiorly and inferiorly. These two small tags of posterior corneal tissue help to preserve the position of the intraocular contents. Even in the face of moderately increased posterior pressure, slight patient movement, or coughing to some extent, we would expect the intraocular structures such as the iris and the posterior chamber implant to remain intact. There is a clock hour of tissue holding the button in place at 12 o'clock and 6 o'clock. A small amount of viscoat is placed on the corneal surface in order to create a barrier between the host button and the donor button, which will be placed centrally over the host cornea. And now 6 sutures will be put into position at the 3 and 9 o'clock position and just slightly above and below. This will just leave enough room to have easy access to cut the remaining posterior corneal tissue holding the host button in place at 12 o'clock and 6 o'clock. Previous studies have shown that there is not a significant decompensation of the donor endothelium that occurs during these types of maneuvers. The 6 sutures put into place are sufficient to also maintain the position of the intraocular contents and prevent any intraoperative mishaps. After placement of the 6th suture, we will turn our attention back to the host corneal button. The posterior corneal tissue will be cut by corneoscleral sutures, and then the host corneal button will be slid out from within the anterior chamber, and we will be free to complete the rest of the transplant suturing process. Clock hour of remaining posterior tissue is cut inferiorly and cut superiorly as well. The host button is then slid out from underneath the donor and removed and passed on to the assistant. At this point, we are free to complete the suturing of the penetrating keratoplasty graft as we would in any other circumstance. By performing the transplant in this way, we should be able to minimize the risk that one typically encounters when doing a penetrating keratoplasty in an open sky technique, as intraocular contents are more likely to stay in position. There's less chance of iris extrusion, hemorrhage, and expulsion of various intraocular contents. All complications that cannot be completely eliminated, especially since unpredictable factors like patient movement, posterior pressure, bucking when under anesthesia, if general anesthesia is administered, all can occur. Thank you for your attention, and consider this technique the next time it's necessary to perform a penetrating keratoplasty.